100 beds, state-of-the-art medical infrastructure, and more than 40 specialized teams from 21 states.
Surgical teams in the country today. The cardiac hospital within the Narayana Health City campus is one of the largest dedicated cardiac programs or hospitals in the country, where we do over 2,000 cardiac interventions and more than 700 cardiac surgeries every month. This is a scale at which drives all of the visions and missions of the organization in terms of being affordable, accessible, and to do work at a high quality for the masses. This organization was set up over 25 years ago. We are celebrating our 25th anniversary.
Number one, with the patent grafts, it was difficult for us. So what we did was a robotically assisted this thing. So in this, what we, instead of stopping the art, instead of if you have to stop the art, again we have to dissect completely, the art will get dysfunctional. So what we did was, instead of stopping the art, we fibrillated. And
because we became more confident with minimally invasive, then we decided to go with robotics. So in robotics also we started with something which is more simpler to us, so that we get used to the procedure. And now, as Dr. told, we have moved on to more like a complex case, which we are doing it regularly and with much ease. And you can ask Dr. Kumar to speak more.
Respected people from the media and my friends and colleagues. I'll have a small presentation, so it won't take much time. It will take about 4 to 5 minutes. So, and then we're happy to, me and my team will be happy to answer the questions. So initially we started with minimally invasive cardiac surgery, and we've been doing it almost for a decade now. And in last 2-3 years, we started venturing into advanced technology of robotic cardiac surgery.
Technology-driven surgeries, it used to be like the company-driven. So now with so much of publicity, the patients come and ask for all these procedures because of the aestheticness, minimal scar, and the least pain, and less bleeding, and back to work at the early.
Nothing much more to add apart from a lot of things have been explained by my senior colleagues. One thing which I would want to say a little bit off the topic is, as you can see, I am the youngest surgeon in the ladder. So the beauty of Narayana Health is that I was trained in Narayana Health in cardiac surgery, and I continued as a consultant. So we have seen the shift of patients initially getting the routine midline sternotomy surgeries, and then what Dr. Nitin said, that Dr. Shetty felt that the future of cardiac surgery lies in going minimally invasive. And over the years, we have seen the number of minimally invasive cases are going on increasing. And if you see our OT list,
ನನ್ನ ಹೆಸರು ಅರುಣ್ ಕುಮಾರ್ ಅಂತ. ನನಗೆ ಬೈ ಬರ್ತಿಂದಲೇ ಹಾರ್ಟ್ ಇಶ್ಯೂ ಇತ್ತು. ಚಿಕ್ಕ ವಯಸ್ಸಲ್ಲಿ ಚೆಕ್ ಮಾಡುವಾಗ ಆವಾಗ ಏನು ಆಪ್ರೇಷನ್ ಏನು ಬೇಡ, ಅದು ಹೋಗಿ ಆಟೋಮೆಟಿಕ್ಕಾಗಿ ಕ್ಲೋಸ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾವೇನು ಚೆಕ್ ಮಾಡಿದಾಗ ಬಿಟ್ಬಿಟ್ಟಿವಿ. ಇಲ್ಲಿ ಬಂದು ಚೆಕ್ ಮಾಡುವಾಗ ಡಾಕ್ಟರ್ ಸತೀಶ್ ಡಾಕ್ಟರ್ ಅವರು ಒಂದು ಮತ್ತೆ ಹೇಳಿದ್ರು, ಓಪನ್ ಹಾರ್ಟು ಬೇಡ, ನನಗೆ ಸೈಡಿಂದ MICS ಅಂತ ಒಂದು ಮೆಥಡ್ ಬಂದರು, ಅದರಿಂದ ಮಾಡ್ಬೋದು ಅಂತ. ಅವರು ಒಂದು ಡಾಕ್ಟರ್ ರಘುಲ್ ಅಂತ ಒಂದು ಸಾರಿದ್ದಾರೆ, ಅವ್ರಿಗೆ ರೆಫರ್ ಮಾಡಿದ್ರು. ಅವರು ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿದರು, ಇದು ರೊಬೋಟಿಕ್ ಟೈಪಿಂದ ಮಾಡ್ಬೋದು, ಅದು ರಿಕವರಿ ಟೈಮು ಕಡಿಮೆ ಇರುತ್ತೆ ಅಂತ. 5 days ಆಯಿತು ಸರ್ಜರಿಯಾಗಿ, ಪರವಾಗಿಲ್ಲ, ಏನು ಇಶ್ಯೂ ಇಲ್ಲ, ಚೆನ್ನಾಗಿದೆ.
System. And the robot has entered cardiac surgery almost about 2 decades ago, but in the meantime it has got found out, and now in the last almost 8-9 years, the robotic cardiac surgery, robotic has entered the cardiac surgery. So we now, in the initial phases, you have been choosing the cases right cases for the robotic procedures. But as when we keep pushing the boundaries, soon in future, most of the cases we will try and do by robotic system. And to know like which is the ideal patient as of now, like we choose the patients like whose the heart function is good and no anatomical challenges and his vasculature is good. So we choose these 3 patients for the robotic procedures. And as we discussed, like for the robotic system, like for the cabbages, for the coronary artery bypass grafting, where the lungs has to be good, because we do most of these cases in single lung ventilation. So if they can be able to maintain oxygenation with a single lung, yes, we go ahead and do a robotic system. And other challenges is the vasculatures. There should not be like a peripheral vasculars has to be good. There should not be a calcium burden or atherosclerosis burden in the peripheral vascular system. Yes, those patients we choose for the robotic procedures.
ಇಟ್ಸ್ ಅ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ಸ್ಟೇಟ್ಮೆಂಟ್. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ತುಂಬ ವರ್ಷದಲ್ಲಿ ಈಗ ನಾವು ಮಾಡ್ತಾ ನಮ್ಮದು ಎಕ್ಸ್ಪರ್ಟೀಸ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ. ಸೊ ವಾಟ್ ವಿ ಥಾಟ್ ವಿ ಕುಡಂಟ್ ಡೂ ಬಿಫೋರ್ ವಿ ಸ್ಲೋಲಿ ಗ್ರ್ಯಾಜುವಲಿ ಇಂಪ್ರೂವ್ ಅಪಾನ್ ವಾಟ್ ವಿ ಡೂ. ಸೊ ಇಂಪಾರ್ಟೆಂಟ್ ಏನಂತ ಹೇಳಿದ್ರೆ ಪೇಷಂಟ್ ಸೇಫ್ಟಿ ಇಸ್ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಸೊ ಮುಂಚೆ ನಾವು ಮಾಡ್ತಾ ಇರ್ತಿರಲಿಲ್ಲ, ಈಗ ನಾವು ಮಾಡ್ತಾ ನಮಗೆ ಅಂದಾಜಿದ್ರೆ ಅರ್ಥ ಆಗುತ್ತೆ ಯಾವ ಪೇಷಂಟಿಗೆ ಸೇಫಾಗಿ ಮಾಡ್ಬೋದು. ಸೊ ಅದೇ ನಾನು ಮೀಟಿಂಗಲ್ಲಿ ಹೇಳಿದಾಗ ಮುಂಚೆ ನಾವು ಅರೌಂಡ್ 10-15% ಕೇಸಸ್ ಮಾತ್ರ ನಮ್ಮ ಒ ಟಿ ಲಿಸ್ಟಲ್ಲಿ ಮಿನಿಮಲ್ ಇನ್ವೇಸಿವ್ ರೊಬೋಟಿಕ್ ಮಾಡ್ತಾಯಿದ್ವಿ. ಇವಾಗ ಪೇಷಂಟಿದು ಸಿಚುವೇಶನ್ನು, ಕಂಡೀಷನ್ನು, ಬ್ಯಾಕ್ಗ್ರೌಂಡ್ ಅರ್ಥ ಮಾಡಿಕೊಂಡು ಇವಾಗ almost 50% to 60% of cases are more than that being done through minimal invasive and robotic. So and considering the fact that ನಮ್ಮ patient subset, ನಮ್ಮ Asian patient subset ನೋಡಿದರೆ they are with bad vessel targets, ಅಂದರೆ ಅವ್ರದ್ದು ರಕ್ತನಾಳಗಳು ಅಷ್ಟು ಚೆನ್ನಾಗಿರಲ್ಲ. ಈಗ ಕಾಕೇಶಿಯನ್ ಅಂದರೆ ಅಮೇರಿಕನ್ ಪೇಷಂಟ್ಸ್ ನೋಡಿದರೆ ಇನ್ನೂ ಅವ್ರದ್ದು ದೇರ್ ಬಿ ಬಿಗರ್ ಪೇಷಂಟ್ಸ್ ವಿತ್ ಬಿಗರ್ ವೆಸಲ್ಸ್. ಸೊ ಆದ್ರೂ ನಾವು ಮಾಡ್ತಾಯಿದ್ದೇವೆ, ಯಾಕಂತ ಹೇಳಿದ್ರೆ ನಾವು ಡೈಲಿ ಮಾಡ್ತಾ ನಮ್ಮದು ಎಕ್ಸ್ಪರ್ಟೀಸ್ ಜಾಸ್ತಿ ಆಗ್ತಾಯಿದೆ. ಸೊ ದಟ್ ಈಸ್ ವೇರ್ ವಿ ಆರ್ ಗೋಯಿಂಗ್. ದಟ್ ಈಸ್ ವೈ ವಿ ಬಿಲೀವ್ ದಟ್ ಓವರ್ ದ ಕೋರ್ಸ್ ಆಫ್ ಟೈಮ್ ದಿಸ್ ಈಸ್ ಗೋಯಿಂಗ್ ಟು ಬಿ ಅ ಗುಡ್ ಬೆಂಚ್ ಮಾರ್ಕ್. ಪೇಷಂಟ್ಸು ಕೇಳ್ತಾರೆ and a good number of percentage of patients will be eligible for robotic heart surgery.